Welcome to Harlow on Healthcare. I'm David Harlow, and I invite you to join me by my virtual hearth as I sit down with healthcare leaders to discuss building the future of healthcare. Today, my guest is Stephen Lane, MD, MPH, Chief Medical Officer at Health Gorilla, a platform for interoperability in healthcare, providing permitted access to actionable patient data, and as of this date, a recently approved participant in the new QHIN program promoted under TEFCA. Stephen is a primary care physician and clinical informaticist who is committed to improving health and care for all through privacy-protected health data access, exchange, and use. Stephen, welcome and thank you for joining us.
Thank you, David. Happy to be here.
So to kick things off, I would ask you to delve slightly deeper than the tagline intro to Health Gorilla and let us know what Health Gorilla is all about. And then we can segue into a discussion of the QHIN journey and what that means both for Health Gorilla and for all of us.
Wonderful. Health Gorilla is a roughly 8-year-old Silicon Valley startup. It was begun by my now friends who were initially trying to solve problems for practicing physicians here in the community where we all live. And they started by working on connectivity for practices who wanted to place laboratory orders and get their results, and quickly learned that there was much more needed in the interoperability space to support physicians, providers in the community, especially those who were not enjoying the benefits of advancing interoperability tools that were made available through the major EHR vendors. So while they were working on that, I was working in a large health system and implementing interoperability. And then our paths crossed a few years ago as my health system was utilizing the care quality framework for nationwide interoperability, and we started exchanging with other providers who were using the Health Gorilla network. And what I learned was that this was a very innovative team that were willing to push boundaries to solve problems in the clinical workflow. And not only that, they were very engaged and interested in working with others, collaborating, learning to move forward all of the challenges related to health data exchange. So when I came up onto my 30th anniversary in my primary care practice at Sutter Health, I decided that I wanted to make an even deeper commitment to advancing interoperability. So now I'm just doing a limited clinical practice and really focusing in with Health Gorilla as they try to really advance the cause, leveraging this new opportunity of the Trusted Exchange Framework and Common Agreement, or what we call TEFCA. The TEFCA framework allows or really requires that a handful of qualified health information networks stand up a skeleton that will allow for exchange over this new interoperability framework. And as you mentioned earlier this week, Health Gorilla was one of the 6 organizations that was named to proceed forward with the formal testing and implementation process before full designation as a QHIN under the new framework.
So there is today perhaps greater appetite for this sort of interoperability than there was in the past. I'm not sure that it's espoused by all quite yet. But maybe you could tell us a little bit about the journey. There have been times in the past, and these maybe still continue, where many of the EHR systems are considered to be walled gardens, even in the face of interoperability mandates or even the technical opportunities. Have you seen, both in your clinical practice and in your work with here, the demand for interoperability and information exchange growing over time?
Absolutely. And I'm happy to put this into an historical context. As a physician, I first used an electronic medical record in 1989 when I was an emergency medicine physician. And that was pretty early days, right? There weren't many EMRs back then. And it struck me immediately the potential power for digitizing healthcare data. And fast forward in 1999, I helped to implement one of the first instances of the Epic electronic medical record. We rolled that out. And then about 15 years ago, as EMR, then called EHRs, were being taken up more broadly by practicing physicians and hospitals, we really saw this need to address the problem, as you said, of the walled garden, the problem of data staying in the system where it was generated. But of course, patients move and their care moves over the course of sometimes an episode of illness, sometimes over the lifetime, but almost everybody ends up needing to have their data move with them. Again, I was using an EHR system from a vendor that was particularly committed to implementing interoperability tools, initially to support different customers using their system, and then as it became possible to support exchange across different vendor systems and across networks. I've definitely seen this grow. I've been right on the point of that spear since interoperability started. Early on, it was a little shocking for a lot of people to think that they were going to be sharing their data electronically as opposed to the old-fashioned paper, fax, etc. types of processes. But we've grown and we've had tremendous progress made to the point now that the vast majority of hospitals and a substantial proportion of office-based clinicians have electronic health records that have connectivity. Working closely with the Office of the National Coordinator for many years, we've seen the advancement of what was initially called the Meaningful Use and now the Promoting Interoperability Program. So there were incentives, there was money invested in digitizing healthcare and in requiring the systems that do this work to follow technical standards and to be able to share data amongst themselves. So as part of that, I helped to stand up the care equality interoperability framework that exists today that allows for this cross-vendor and cross-network exchange. It was actually one of my patients that had the very first exchange of data on the existing framework. And then I've had the chance to work closely with the ONC over the past 7 years now on the Health IT Advisory Committee within HS, which has also been helping to advance interoperability, building off of the 21st Century Cures Act, which brought us the Trusted Exchange Framework. It brought us the information sharing requirements. It's brought us additional incentives and support for the use of next generation technology standards, the FHIR, the Fast Healthcare Interoperability Resources Standard for data structure and for exchange. So all of this is moving forward simultaneously. As you mentioned earlier, we just passed an interesting and an important milestone where the early participants in the TEFCA are starting to be identified. We're moving into more formal technical testing. And I think we're really going to see a lot of the promise of interoperability unlocking here over the next few years. We've seen, as I said, a tremendous uptake of exchange between providers for treatment purposes, but we still have a lot of challenges when we look at exchange for payment, exchange with the payers, for healthcare operations. We obviously have come through the pandemic over the past few years, seen all kinds of challenges with public health data interoperability. And then there's the whole world of community-based social services, of patient access, of all of the insurers who need to get health data to manage their underwriting and their processes. There are many stakeholders to health data interoperability that really have not enjoyed the benefits. So I think the idea of the TEFCA is to build on everything that we've done with EMRs, with health information exchange networks, with the community-based HIEs, bring that all together under the same umbrella. The vision of the TEFCA is to have a single on-ramp that will allow participants to gain access, exchange, and use health data without special effort. And I think we have the technology and the foundation to really make good on that promise. partners. But this has taken a long time. We've been at this, as I said, for a good 15 plus years. And I think it's going to take us a number of years more before health data moves around the ecosystem as easily as, say, your financial or banking data or your travel data when you're making a reservation to go on a trip. We see the application programming interfaces, the API, the modern web tools really having transformed so many industries. Healthcare is special. It's complicated. It's very important that we get it right. But I think we have the pieces of the puzzle on the table that we can now assemble to paint that picture of true health data interoperability.
Sure. So when we say health data, it really means a number of different things, right? There are standards in terms of data sets, data elements in the EHR, in the EMR. There's other standards that apply to different sorts of records, whether it's lab or radiology or pharmacy, other kinds of bits of information that are important for the insurers, quality data that's important across the board. And there are elements of the ecosystem that lie outside of the reach of HIPAA for the most part, or at least in some part, and have therefore also been outside the reach of some of this integration effort. And I'm wondering if you could speak to a little bit further to the breadth of the integration efforts that are now underway. Do they reach the digital health and the device and the activity monitoring realms that are not within the realm of quote unquote traditional health?
Well, you asked a whole long list of questions there, and I'll try to unpack some of that.
Sure.
So the scope and the range of health data, and you notice I intentionally call it health data and not healthcare data or EMR data, which of course is a subset of health data. I think of health data as really being all of the data that impacts our health. And that includes our activity, it includes our diet, it includes our genomics, it includes so many different aspects of life, social drivers of health. There is just an expanse of data that impacts our health. Even the climate, for example, there's so much there. And clearly the focus has been on healthcare data, has been on this core data set that has been defined in legislation over the years. And there was something called the Common Clinical Data Set under the High-Tech Act. And then with the advent of the 21st Century Cures Act, we got the U.S. Core Data for Interoperability, or USCDI, which has continued to evolve year after year. I've been intimately involved in the advancement of that standard, which defines the specific data classes, data elements, and the associated technical standards, which is meant to define a floor of health data interoperability for the country and really for the planet. It's not very different when you cross borders or go overseas. So I think that those standards, the USCDI, then references a number of other standards, as you were suggesting. There are many standards development organizations that for decades have been managing the advancement of the technical standards, both for the data and for the exchange. And I think that over time, what we're seeing is a progressive expansion of the availability of standards. SDOH, Social Drivers of Health, is a perfect example where we didn't have a lot of standards. Everybody's known for years that many of the determinants of health are social in nature and not directly related to the health care that we provide. But we didn't have standardized ways to capture that very critical information. And now that's happening. The Gravity Project and others have been working to define what are the dimensions of SDOH, what are the data elements, what are the technical standards. And then in my current company at Health Gorilla, we're in the process of piloting that, of trying to expand the sources of SDOH data, and then bringing that together with clinical data, with laboratory data, et cetera. So as you suggested, no matter what domain you look into, there is there's a need to identify what are the critical data classes, data elements, technical standards, and how do we bring those together so that eventually we have truly a holistic view of an individual or a population, that we have access to the rich data that is then going to inform our care. And I think that's really important because we don't know what we don't know. And there are many factors that impact the care and the health of individuals and populations. And it's really only once we bring all of that together and we leverage the power of modern technology, the power of cloud computing, of supercomputers, of AI and ML, that we're going to begin to see the signal in the noise, which is all of this expanse of heterogeneous health data. And I think that, again, that interoperability, the ability to exchange that data, to bring it together, to access it simultaneously, is a key component that's going to allow us to drive that forward.
If you're just tuning in, this is Harlow on Healthcare, coming to you on Healthcare Now Radio. I'm David Harlow, and my guest today is Stephen Lane, Chief Medical Officer at Health Gorilla. Stephen, we've been talking about a variety of different types of data and sources of data, and I'm wondering whether all of these different types of data are currently within the realm of what is being integrated or what's contemplated under TEFCA, under the QHINs, or is some of this aspirational for the future from your perspective?
I think the latter. I think that we aspire to bring together the many types of data that impact health and to be able to use those in a standard computable format. As we were discussing, healthcare data has been digitized now for 20 plus years. That is becoming more and more standardized. Certainly, payment data, claims, and the data that health insurers use has been digitized for at least that long. But there are many types of data, patient-generated health data. We were talking a bit about social drivers of health. There's a lot of information that impacts health that is not fully digitized, that is not standardized, that is not yet being readily exchanged. And I think that that's where the aspiration comes into play. But we see increasingly, and again, here at Health Gorilla, they have been progressively expanding the types of data that they are incorporating in the health information network that they support. And I think as we move forward into the era of TEFCA-based exchange, we're going to see the same. We're going to see increasing data types. We're going to be seeing increasing participants. We're going to be seeing support for more use cases as this moves forward.
With your informaticist hat on, do you see the current or near future ability to use that data in order to promote health, in order to measure health, in order to influence outcomes?
I do. And I think that we're seeing this today. Again, as a clinician, my window on health data has largely been through an electronic health record. And what we see is a progressive advancement of the standards of functionality within those records. So the Office of the National Coordinator for Health IT certifies electronic health records, and the standards of certification do continue to advance as it is recognized that additional functionality is required, or that functionality is so well established that they no longer need to have people testing or certifying to that. So I think that world is clearly moving forward in a stepwise manner. There are other participants in health and in healthcare that have not been so digitized, that have not had standardized systems. The long-term post-acute care community, for example, nursing homes, et cetera, really only more recently came to be utilizing electronic health records. The pre-hospital care, the EMS systems have also been actively implementing and standardizing their use of electronic systems. So to the point now that we can look at meaningful data exchange between an EMT or paramedic working in an ambulance and an emergency department that's going to be receiving that patient. These transitions of care are particularly challenging because they're high-risk events for the individuals involved. And the importance of being able to collect and transmit and share data cannot be overstated. So I think that what we're seeing is the digitization of more and more aspects of health and social care. You think about social services, think about behavioral health, a lot of areas of health care which are so important to our outcomes and our population health, really have only recently started to become digitized. We had the advantage in traditional medicine, medical care, that there was an infusion of federal dollars that really incentivized the uptake of electronic health records. And that was not without its challenges and unintended consequences. And I and other physicians have had to experience that pioneering transition from a paper-based system to an electronic system. And I think we'll go through similar growing pains across health data spectrum as we see digitization come in and move forward.
So what do you see as the hot issues or key blockers that stand between us and the future, so to speak?
There are quite a few. One of them is this notion that I think really is real and persistent of data silos, of holders of data having reluctance to exchange the data that they have. And there are many examples of that, whether you're talking about providers or payers or behavioral health or social services or labs. We could dive into any of those. The reality is that we now have the new 21st Century Cures Act final rule, which clarifies the need for holders of data, actors under the rule, which includes providers and health information networks and exchanges and developers of certified health IT, that they cannot block the exchange of data, except when required by law or in very specific, narrow, exceptional cases. So I think that rule, which really only came into full function last year, really is going to play an increasing role. We are still waiting for clarification of the penalties and the disincentives for information blocking. But I think that all of the actor categories that are impacted by that rule are on notice. They know it's out there. They know it's coming. But I think a lot of folks are waiting to see what will be the consequences of information blocking. And only once we start to see that play out, I think, will we see that needle really make continuing progress. Of course, on the payer side, CMS has been driving those rules in terms of freeing up data that payers have to share that with patients, with providers, with other payers. The idea of one payer sending their data to another payer is pretty challenging, right? Old business models are going to fall hard. We can talk about price transparency.
Right. On those two fronts, so we're several years into the price transparency rule for hospitals, for example, and I think the returns would say that we're doing okay, but not great in terms of compliance there. And now we're kicking that off with the plans. And I guess the question will be, will the plans do any better on the transparency front? Is the rule making being accomplished in a way that is really driving behavior change? And is there something else that can be done? Or are there other levers that can be used to motivate change like this?
I think that we're really getting to human behavior and the functioning of the marketplace. And what I've seen in 30 plus years in this space is it's great to focus on the greater good to have people come forward and make advances because it's the right thing to do. Then you need to start to motivate and incentivize folks to do things that need to be done. And then you have to move on to penalties. And I think for a lot of these things, especially when the exchange of data, the use of data, the transparency of data threatens established business models, really penalties end up being the thing that starts to move the needle the way it needs to go. So I think it's the way our society functions, but we need to go through that process of the early adopters, focusing on innovation for the greater good, to the incentives and then the penalties. And I think that whether you're talking about price transparency, whether you're talking about data sharing, whether you're talking about lowering barriers to patients being able to access their own health information from the various holders of that data, I think the penalties that we see coming will really help to define that. When you look at, for example, HIPAA, it's been around for ages now, and it's really just been over the past few years that you've seen the federal government more significantly penalize, especially provider organizations that have made it difficult for patients to access their data using the old traditional methods. And I think that there has been a concerted effort there to free up the data, to lower the barriers to access. And I think that we'll see similarly those kinds of disincentives applied to the electronic access to data over the next few years.
So, Stephen, to wrap things up, I'd like to ask you, if you were to wake up tomorrow and find yourself 5 years in the future, what's one thing in healthcare that you would hope or maybe expect to find has changed drastically?
It's interesting. We discussed this with Mickey Tripathi, the National Coordinator for Health IT, when we were all together in DC earlier this week. And I don't think that a light switch is going to go off and then suddenly all of the barriers to health data exchange, access, and use will go away. But when you put up the horizon line of 5 years, I think we're going to see a lot of change. We've certainly seen a lot of change over the past 5 years and the 5 years before that. That's a cycle of time when real change can happen. And I think that with the dawn of TEFCA, with the advancement of the information sharing requirements, with the coordinated rulemaking that we're seeing across federal agencies and with states getting more involved, I think we're going to see real advancement. And I think 5 years from now, you're going to wake up, and when you go to see a healthcare provider, they are much more likely to have ready access to more of your health data. Probably not all of it because of the standards work we need to do, but more of it. It will be more readily available. It will be more organized. It will be more reliable because it will be higher quality and based on more established technical standards. And I think that we will begin to see what we've been hoping for, which is that patients will have more of an opportunity to understand their healthcare options, the cost implications of those options relative to whatever payment scheme they're involved in, and we'll be able to make more informed decisions. I think similarly, caregivers, family members will have more ready access to data, and we will see care teams being able to function more efficiently. I think transitions of care will become increasingly smooth and safe as more data flows between different members of the care team and the healthcare system. And I really do think that within 5 years, we will see demonstrable difference. I'm hoping we're also going to be doing a better job measuring all of this. I've been involved in a number of efforts over the last 5 or 10 years to try to measure interoperability and to try to measure the impact of data sharing. And there are a number of groups involved in that, and I think we will see quantitative progress as we improve that measurement.
Thank you. Thank you, Stephen, for joining us.
It's been my pleasure, David.
You have been listening to Harlow on Healthcare. Join us at healthcarenowradio.com. Let's continue the conversation on building the future of healthcare together at #HarlowOnHC. I'm David Harlow, keeping the fire going and holding a seat open for you. Until next time.